everyone, welcome to the Managing Mito webinar on pregnancy guidelines with Mito. My name is Abby Mason. I'm a support services officer with the foundation. I've also got my colleague Kira Lee in the background there helping me out with the technical side of things. So she's there, to back us up if we have any issues. I just wanted to run over a few things before I introduce today's guest speaker. So we will have a Q&A which will be through the chat. So if you've got any questions that pop up throughout, feel free to put them through, and at the end we'll have some moment there to go through any questions that you might have. I wanted to add a little disclaimer. The information shared in this session is for general purposes only. We won't be answering any personalised or giving personalised advice, sorry. We won't be addressing individualised questions. We would recommend you seek personal advice from a professional in the field regarding your specific situation. Let me go ahead. The Mito Foundation acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to the elders past and present and extend that respect to the Aboriginal and Torres Strait Islander peoples that may be on today. I wanted to acknowledge people within the community that have a lived or a living experience with Mito. Those who love and care for them. Each person's journey is unique and a valued contribution to our commitment to end the suffering from Mito. We respect the value, your generous contributions, which assist us to continually shape the work we do. So thank you to everyone. Just a little quote there from Alice, a community member, about the importance of Mito community being a parent. To have a little read. All right, I'd like to welcome our guest speaker, Lisa Hu. Sorry if I got that wrong, Lisa. I'm sure you can correct me if I have. Professor Lisa is a maternal fetal medicine specialist and professor fellow at the Mercy Hospital for Women. She chairs the Informed Decision Making for Pregnancy and Parenthood working group with the Mito Hope pilot program, and recently published a literature review with clinical guidance on antenatal care of women with Mito. So I'd like to invite Lisa to share her presentation, and any questions that come through, please put them through the Q&A and we'll address them at the end.
Hey, thank you very much for the opportunity to talk and to share the findings from our literature review with the Mito community. Now, can I just check you can see my slides? You can see the correct screen?
All good, yes.
Great, thank you. So as Abby introduced me, I'm a maternal fetal medicine specialist, and if you haven't heard of that before, that's an obstetrician who has a special interest in pregnancies that need additional care, particularly pregnancies where the woman has a medical condition or where there's a suspected health condition in the baby before birth. So we do a lot of additional work in multidisciplinary teams with physicians and work in ultrasound and prenatal diagnosis. So I'd like to start off by acknowledging the traditional owners of the land on which I live and work. I'm in Melbourne, and I'd like to pay my respects to the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past and present. So I think for those of you who are here and those of you who are going to be watching the recording, I think you've already gotten off to a very good start by actually thinking about preparing for pregnancy, because we know that for the general population, about 50% of pregnancies are unplanned, and people may miss out on opportunities to optimise their health and get their pregnancy off to the best start possible. So in this talk, I'm going to talk specifically about issues that are relevant to women with Mito. So the effect of pregnancy on a woman's health, and then the effect of mitochondrial conditions on outcomes of pregnancy. And then in the second part of the talk, I'll talk about the advice that we give all women, regardless of what their background health issues are, and general advice about optimizing health and some pre-pregnancy tests that they may wish to consider before conceiving. So I like to think of pregnancy as a bit of a marathon followed by a sprint, because even though you may not be aware of it, during pregnancy, your body is doing a lot of additional work. Your heart is pumping harder and faster. Your blood volume increases. Your blood pressure actually lowers, and that helps perfuse and supply nutrients to the developing baby. And your breathing is deeper and faster. And then, of course, the sprint right at the end of the 9-month marathon is labour. So if a woman's having a vaginal birth, contractions and pushing, and then the blood loss and cardiovascular adaptation after birth are additional stress on a woman's body that requires additional consideration if a woman already has a pre-existing medical condition. And then things don't actually stop there. There's also parenthood. So pregnancy might be a marathon, birth might be the sprint. Parenthood, I think of it as a bit of a steeplechase. It's like a long distance run with random hurdles all over the place. And I think we can't underestimate the additional work it takes to be a parent. And I'm sure some of you already know that, but for those of you who haven't had a baby before, you may observe what it's like for people around you with infant feeding and settling, particularly in that first year where you're not getting as much sleep as you would like, and then all the challenges of a growing family. So these are all the things that lie ahead, and a wonderful thing to look forward to, but also something that is worth kind of being as informed as possible about before you embark on this. So when we talk about what to expect when you're expecting, some people think that pregnancy is a period where women are glowing, they're feeling at their best, but the reality can be quite different. So some of the normal symptoms of pregnancy are things like feeling tired, being a bit out of breath, having nausea and vomiting, or what we call morning sickness. But for a lot of women, it's not just in the morning, it's all day and sometimes for the entire pregnancy. It's very common to have symptoms like heartburn or reflux because the acid in your stomach is more likely to sort of just reflux up into your esophagus during pregnancy because your normal mechanisms that keep it in the stomach are not working as well. Fluid retention is also a very common and normal part of pregnancy, and that can result in puffy ankles and hands. And it's also normal for other organs to be changing. Your breasts will get bigger and they can feel more tender. There are also some other things that happen. Pain, back pain, leg pain, pelvic pain, and trouble sleeping. And then it's very common to get a change both in your bowel habits and also how often you have to go to empty your bladder. So women find that they're going to the toilet more often at night to empty their bladder just because there's not as much space for the bladder to fill once the baby's moving down into the pelvis. And because of the hormonal changes in pregnancy, it's very common to be a bit more constipated than usual. So all of these delightful changes are what we would actually consider normal changes in pregnancy. So it's important to be aware that, that these things are something that go along with being pregnant. They're not necessarily signs of anything concerning or worrying, but something to be aware of. And so for women with mitochondrial conditions, all of these additional challenges of the physiological stress of pregnancy, plus all of those troublesome symptoms, they can make the whole experience quite variable. And so we thought it would be a good time, given the upcoming clinical trial of mitochondrial donation in the Mito Hope study, for us to look at what's published in the scientific literature about pregnancy outcomes for women with Mito. So we included all studies from the year 2000 to 2023. We didn't want to include studies that were older than that because we thought that medical care and diagnosis has advanced so much in the last 23 years that what would be reported earlier might not be that relevant for women that we are seeing today. So looking through all the scientific literature from the medical databases, we found 24 studies that looked at outcomes of pregnancy for women with mitochondrial disorders. 5 of the studies were based on questionnaires. So these were studies where centres that had a big group of women that they'd been looking after for many years with Mito were sent questionnaires. And these women responded and reported what happened in their previous pregnancies. So there are a total of 322 women in those 5 studies that shared their prior experience of pregnancy. And then we had 19 studies, which were individual case reports. So that means doctors who looked after a woman in pregnancy thought that there were some specific lessons that other people could learn from, and so they published the outcome of one individual. So these combination of the questionnaire studies and the case reports kind of informed our general recommendations for pre-pregnancy and pregnancy care. So first of all, how does pregnancy impact a woman's Mito disease? So the first thing to say is most women coped with pregnancy very well and had live, healthy babies at the end. But as you might expect, there were quite a lot of symptoms experienced by these women. At least 1 in 3 women who were answering these questionnaires said they had worsening reflux and heartburn. Their fatigue was more pronounced during pregnancy. Some of those who had muscle pain and cramps as part of their Mito found that it got worse during pregnancy. And muscle weakness and exercise intolerance was also experienced by at least 1 in 3 women. Other issues such as nausea, vomiting, and constipation were also common, as were balance problems, memory problems, and headaches. So although that seems like quite a long list, I guess you have to remember that this is very common even in women without Mito. So it's very hard for us to know how much of these symptoms were just normal pregnancy related changes and how much had additional impact from the woman's Mito disorder. So that's kind of the first lot of information that we learnt from these studies. And then from the case reports that outlined outcomes for individual women, that's where we could see some of the more severe or adverse outcomes reported. So these were individuals who had very severe complications to their health. And although we don't expect many women to have these sorts of complications, it's important for us to know that it is possible so that we remain vigilant and support women to get through pregnancy and bring their babies home safely. So the most important thing really is that the pre-pregnancy function of the woman was a really important influence on how she coped during pregnancy and how well the baby did. And that's, I'm sure, not surprising to anyone. And the other aspect was that multidisciplinary team management was considered a really important part of looking after women with Mito. So when we talk about multidisciplinary teams, we mean healthcare professionals and allied health professionals with lots of different types of expertise all working together to look after women. In this graphic here, you will see some examples of some of the severe complications that have been reported in the literature. Some women who had severe weakness and fatigue in pregnancy ended up being hospitalised because they weren't able to manage at home. Other women with respiratory compromise found that it got worse in pregnancy, and some of them required hospitalisation for that. There are also cases of worsening heart function, epilepsy, pain, and metabolic issues. It was also evident from the literature that women with Mito disease have more common complications of gestational diabetes, and that requires blood sugar monitoring in pregnancy and insulin management. For those that get really unwell, there was also some cases of stillbirth recorded. So all of these findings really tell us that although we can be positive about health outcomes for most women with Mito, it's important that they're managed in an appropriate model of care that can look after things if the risks become high. So how did the pregnancies turn out for these women? As I said, most women had very good outcomes, but the sorts of complications that were more common were high blood pressure and something called preeclampsia, which is a pregnancy-related disorder of blood pressure and organ function, gestational diabetes, preterm birth, and fetal growth. So both preterm birth and fetal growth issues are things that we would be very careful in pregnancy to monitor for, because these things can cause more health problems for a baby at birth and potentially result in babies requiring nursery care after birth. If a woman was very unwell, then the risk of preterm birth, a cesarean, and stillbirth was much higher. So these are all the things that we have to consider in the background, even though we generally would think that if a woman has good pre-pregnancy function, her outcomes will be good for herself and the baby. What about after birth, or the birth itself and feeding the baby afterwards? A lot of women with mitochondrial disease can have a vaginal birth. Having a mitochondrial disease is not a reason in itself to have a cesarean, although some women who are severely debilitated in pregnancy, may wish to have a cesarean for particular reasons if labour isn't considered optimal. It's important to keep an eye and avoid excessive fatigue and dehydration in labour. And an epidural or spinal anaesthetic can be used if a cesarean is needed. Infant feeding really is whatever works best for you and your baby. We would always advocate and support breastfeeding, but if that's not possible due to issues with the woman's health or fatigue, then bottle feeding, express breast milk, or complementary feeding with formula. All of these things are really individualised to a woman's particular circumstances. And there are midwives who are lactation specialists who will certainly be available to help support women in their feeding choices. I've just put a link here to a really helpful site. It's the Raising Children website, which is a source of really good information. It's Australian, it's government supported, and it has lots of information about all aspects of having children. So the next, this next bit is really about what you can do to help to prepare for having a family. There are some things we can change and some things we can't. I think the best way to prepare is really understand how Mito affects you and what the choices are that you have for starting a family. And your healthcare professionals, they might involve your Mito specialist. There may be other people involved in your care, such as a neurologist or an endocrinologist. A genetic counsellor may help talk to you about the chances of having a child with a mitochondrial disease as well. And then your family doctor, obstetrician, and allied health staff and mental health professionals may all be appropriate to include in this discussion. And it really, how many people are involved is up to, is individual. It depends on how Mito affects you and who you need to help give you the information you need to discuss having a family. So what are the potential options for having children? There's, of course, the natural way, natural conception, and possibly testing after birth to see how the child is affected by mitochondrial conditions. There are lots of different ways of inheriting or passing on mitochondrial disease. As I'm sure you all know, it's usually maternally inherited, but the way it affects children can be variable and is not necessarily in the same way that it affects the parent. There's also the option of having a natural conception and testing during pregnancy to see the extent of the baby's mitochondrial condition. There's IVF with egg donation, if it's a maternally inherited type of mitochondrial disease. There's also IVF with your own eggs and genetic testing of the embryo. This may be suitable for some people. And then there's also adoption, which is another way of forming a family. So there are lots of different potential ways to have children. Not all of them will be suitable or acceptable to people there, but these are the range of things that may be discussed with you or considered if you go for pre-pregnancy counselling. So if you do go to see your GP or mito specialist or obstetrician, you know, a general checkup of your health and preconception counselling by an obstetrician with ideally extra training in high-risk pregnancy is recommended. And then for women, everyone who's planning a pregnancy, we recommend that their medications are reviewed, that they become up to date with their vaccinations, they start the recommended vitamin supplementation before conception. They do their best to optimize their lifestyle. And then there are optional choices, optional tests for other genetic conditions that people might want to consider before pregnancy. So medication review, it's particularly important for women with mito because many people may be on treatment for diabetes or epilepsy or heart conditions. So most medications are safe in pregnancy. It's important not to stop any of them without checking with your doctor. Many conditions are much more dangerous for a baby if they're not controlled, such as epilepsy. There are some medications that are not safe to take in pregnancy, and there are some blood pressure medications, some anti-epileptic medications that we particularly would want to transition people off before pregnancy. So it's really important to discuss the safe alternatives with your doctor. And then getting good control of seizures, blood pressure and blood sugar before conception is ideal, because all of these conditions, if they're not well controlled, can affect early development of the baby and lead to pregnancy complications. Vaccination is another really important topic. It's so much better to prevent a disease than to treat it. And before pregnancy, we recommend that all women are up to date with their vaccinations for these conditions. Rubella is something that most of us are immunised against as a child if we were born in Australia. It's an important cause of birth defects, so it's really a good idea to get immunised for that before you get pregnant. COVID-19 vaccine is also safe to take before or during pregnancy, and pregnant women can get are more prone to becoming unwell if they catch COVID-19 compared to when they're not pregnant. And this can increase the risk of preterm birth and stillbirth if they become unwell during pregnancy. Influenza, chickenpox and hepatitis B are also recommended to be immunised against before pregnancy. During pregnancy, there's actually some vaccinations that we recommend, and one of them is a whooping cough booster. And this is actually to help protect the newborn baby from whooping cough. When babies are born, they're offered a course of vaccination, but their immunity doesn't really get established until they're a few months old. So if a woman gets a booster during pregnancy, her antibodies pass across to the baby, and the baby is born with protection from the mum. So every woman will be offered a whooping cough vaccine in the second trimester of pregnancy. We also recommend flu vaccination during the flu season, because the flu is a very common reason for hospitalisation and can lead to intensive care admission for some women as well. So we strongly recommend the flu vaccine during pregnancy. There are also, we'd also support women having their COVID-19 booster if it's due, if it falls during their pregnancy. And the respiratory syncytial virus is also a vaccine that's now recommended in pregnancy. This website here, Sharing Knowledge About Immunisation, or SKY, is a good source of information if you want to read more about it and to have your questions about immunisation in pregnancy answered. There are some infections that can cause issues in pregnancy that we can't prevent with a vaccine. Unfortunately, there are still some of these. One of these is cytomegalovirus. That's a vaccine that a lot of people haven't heard of because it doesn't cause any health problems if you're a healthy adult. But if a woman catches cytomegalovirus or CMV in the first trimester of pregnancy for the first time, it can pass across to the baby and cause some serious health effects. So CMV's passed around like many other viruses in body fluids. It's not spread by coughing or in the air, but it's spread by contact with infected body fluids. So children, as we know, often come home from daycare or preschool bringing lots of coughs and colds and other viruses with them. And they're actually a very common source of CMV infection. So we recommend that women, if they've been in contact with body fluids from their toddler, such as wiping their nose or changing a nappy or feeding them, just to wash your hands properly, pay really good attention to hand hygiene. Kiss your child on the forehead, not on the mouth. You just want to avoid getting saliva into your own mouth. And to that end, not sharing food or cutlery with a toddler is important, just to reduce the contact with infected saliva. Syphilis is another important infection that can cause problems for a baby's development. That's a sexually transmitted disease. And so we screen all women during pregnancy for syphilis, and with early treatment with penicillin, we can prevent any complications for the baby. And then there are some foodborne illnesses like listeria and toxoplasmosis, which can be, your exposure to those infections can be reduced by healthy eating and avoiding ready-to-eat chilled food, soft cheeses and raw eggs and undercooked meat. So this is, again, some information from the Raising Children website, which has some information about healthy eating. So the quality of what you eat is really important. So lots of fruit and vegetables, adequate intake of high fiber, complex carbohydrates and dairy food and good quality sources of protein are really important in pregnancy. Vitamin supplementation is also recommended. Even though we get some folic acid or folate in our diet, it's actually quite hard for women to get the recommended amount of folate in their diet. And so we recommend supplementation with folic acid for all women who are planning to have a baby. If you are on anti-epileptic medication, or you have diabetes, or you've had a prior pregnancy where the child's been affected by a spinal cord defect or spina bifida, we recommend high-dose folic acid. These are both available over the counter from the chemist. And we know that supplementation, starting at least 1 month before conception and continuing through the pregnancy, reduces the risk of spina bifida. And then other lifestyle factors that are important to pay attention to before you conceive: smoking, alcohol, vaping, other recreational drugs. All of these things have adverse impacts on a baby's development and growth. So as much as possible, get support to stop or reduce your intake of all of these things. There's no safe level at which to consume alcohol while you're pregnant, so we do recommend abstaining really from the time you start attempting to conceive. Regular exercise and a healthy weight are also important, both for maintaining your function during pregnancy and also optimizing outcomes and reducing the risk of complications in pregnancy. So I'm sure all of you are very well informed about mitochondrial conditions. There are actually other genetic conditions that affect our population. There are many of them. These are some of the more common ones: cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. And it is now possible to be tested to see if you are a carrier of any of these conditions before you conceive. And this is now funded by Medicare. So this is some links to some websites here. with fact sheets on reproductive carrier screening. And there are also tests which screen for more than these 3 genetic conditions. You can get screening for many, many conditions, but the advantages and disadvantages of these different available tests really should be discussed with your GP or genetic counsellor. It's preferable to be screened for these conditions before pregnancy if you wish to have the testing, because then your options for having a family and a child that's not affected by one of these conditions are much greater if you know about it before you conceive. So finally, if you've made all your way through all of this information and preparation, and you are planning to have your pregnancy care somewhere and you're looking around, it's good to know about the different types of models of antenatal care that are available in Australia if you haven't been through the system before. So there's public antenatal care, that's usually hospital-based. There are different types of care within a public hospital. There are clinics that are led by doctors, and these are typically the high-risk pregnancy clinics. For low-risk pregnancies, women may have midwifery-led care. And then for those women with low-risk pregnancies who have a GP who participates in a shared care program with the hospital, they can have GP shared care. There's also private obstetric care where you have your own private obstetrician, and you may birth in a private hospital or a public hospital if the private obstetrician has visiting rights there. In general, we recommend that women who have a mitochondrial disorder, we recommend that they be looked after by a multidisciplinary team, and that usually works best in a public hospital setting in a maternal fetal medicine unit. Now, I know these are not necessarily available in all regions in Australia. They tend to be concentrated in the capital cities and the larger centres. So exploring what's available near you and seeing what resources are available important. And your GP will know the referral pathways for antenatal care. So again, for more information, I would recommend the Raising Children site as a source of very reliable, sensible information that's relevant to Australians. And it also importantly has a section for partners as well, because we know they can get a little bit left out of these conversations, but they're obviously important to bring along in the journey. And then finally, to conclude, I want to echo this quote from Alice that Abby already read out to you. I think, it's not a journey you embark on alone. As Alice said, I think it's so important that new parents use Mito, new parents with Mito use their village as much as possible. The societal pressure, late nights and breastfeeding were very demanding on my body. You can only be a good parent if you look after yourself. So I hope this has been useful. We have a lot of this information already online on the Mito Foundation website. So we have general advice here and a summary and some information about our general advice for care during pregnancy. And for those of you who are interested in mitochondrial donation as an option for starting a family, there's also some information here. So it's this clinical trial is unlikely to be open for recruitment until late in 2025, but of course we will keep the community updated as much as possible as to the timelines. For those of you who are going to have a pre-pregnancy consultation with one of your healthcare professionals, you are very welcome to download this literature review and the suggested guidance for preconception and pregnancy care from the Australian and New Zealand Journal of Obstetrics and Gynecology. This is an open access paper, so it's freely available to the public, and you can send that link or download the paper and send it or bring it with you to your doctor so that they have the latest information to guide their advice. So thank you very much for your attention. I hope that this was useful. Sorry, haven't been advancing the slides properly. Got too many screens. Here we go. There's the screen with the QR code, which will take you directly to that review paper. And I'm sure Abby and Kirley will have copies that they can send you if you don't manage to download it from this QR code. So thank you for your attention. I hope that was helpful, and I'm happy to answer any questions. Thank you.
Thank you so much for that, Lisa. It was very interesting. Yeah, I'm sure people can take something from that. I mean, pregnancy is a scary thing in itself, and yeah, with a rare condition, I'm sure there's lots of other things that are constantly going through the community's mind. So thank you for your time and sharing that. We did have some questions that were submitted prior that, yeah, I'm happy to read out if you, yeah, be willing to answer.
Yes.
Okay, so the first question is, how often should I see my mito specialist during my pregnancy?
Okay. I guess that is a question about an individual person's circumstance. I can't really answer that because it's going to differ for every person. So I think that's the sort of question to ask when you go for your early visits, or even a pre-pregnancy visit. If your condition's very stable, then you may not need to see your mito specialist that often. If you are on medications that will need adjusting during pregnancy, or it's expected that pregnancy is going to impact that condition, like diabetes, usually women's insulin requirements go up during pregnancy, you may need to see your mito specialist or your endocrinologist more frequently. There are also specialists called obstetric physicians. They are general physicians with a special interest in pregnancy and medical conditions. They may take on some of the role of your they may also have an input into things like blood pressure control, renal function, and diabetes management. So I don't think there's one answer to that, but something to set out and discuss at the beginning. And that's why having a whole team that can work out what your needs are is important.
Excellent. The next one, if my blood pressure is stable now, will I be able to keep it stable as my pregnancy progresses?
Look, it's something that is, for the majority of women, they're pregnant, their blood pressure will remain stable, but it is possible that it will become, may require more medication, and particularly if there's preeclampsia that comes on top of that, which can happen to any pregnant woman, not just a woman with mito. It may need to be, medication may need to be altered. And in some cases, some women need hospitalization, maybe just a day stay, or an inpatient admission if the blood pressure becomes hard to control. So, yeah.
And the other one is around supplements. So obviously fatigue and muscle weakness is a big thing within people with mito. If it becomes worse, is there any extra supplements people can take to help with that impact of the fatigue?
It depends on again the individual, but there aren't particular, there's no magic cure, unfortunately, for the fatigue. The vitamin supplements themselves, probably, as long as you're not iron deficient and anemic on top of that, vitamins and mineral supplements in themselves probably won't have a huge impact on the level of fatigue. It is something that is just part of the extra work your body's doing. And I think ensuring that all the things are optimized, like your iron levels and other things, and are really the best things you can do. But yeah, unfortunately, there's no magic cure for the fatigue.
Yeah. And I just had a couple of questions that popped up in my own mind during you mentioned about your team and someone that's familiar and more of high risk. I know a lot of people are based in regional, so they don't necessarily have people at their local hospital that could supply that high risk care. Is it a kind of default that someone with mito should be considered high risk from the beginning, or is it just dependent on how the pregnancy travels as to whether they need to be, referred to a, larger hospital, for example, to be
Yes.
considered high risk? Yeah.
Yeah. In the first instance, it's important to have that pre-pregnancy consultation to get an idea of what the risks are for you. In general, yes, I think anyone with mito would be considered a high-risk pregnancy. The word high risk can, be a bit frightening. It doesn't necessarily mean you are going to need a lot of intervention or end up with a cesarean or in hospital, but it just means that you have the right experts around to look after you if things don't go as planned. So for women who live in the country, sometimes they can access specialised care in a tertiary maternity hospital that might require travelling to the city for 1 or 2 visits. It may be done by telehealth in conjunction with your local doctor. There are lots of different models. In general, someone with a high-risk pregnancy who lives in a regional area, we can often put together a sort of a shared care plan so that they see all the relevant specialists early in pregnancy, but most of the routine pregnancy visits and checkups are done locally, with visits to the tertiary hospital maybe several times during the pregnancy, and perhaps seeing the tertiary hospital for any specialised ultrasounds that are needed to check on the baby's growth, and potentially coming to a bigger centre to give birth, because that time around labour and the postpartum period can be times when someone's metabolic balance goes a little bit awry. But again, it depends on the type of mito that someone has. If it's something that's just limited to one organ and not really doesn't affect things like the heart or the lung or blood sugar control as much, then perhaps it's not so, things may not need to follow that high risk model. But overall, I think it's important to get specialist advice early so that you know what lies ahead.
Excellent. Sorry, I'm just checking.
I do have a question.
Go ahead, Kira.
So you mentioned there around anesthetics. I know a lot of people with mito have, it's not recommended to have anesthetics. Is that something to discuss, I guess, when is the time to discuss that before pregnancy?
It can be discussed before pregnancy or probably during pregnancy. Might be an easier time. Look, it's not necessarily easy to get access to pre-pregnancy counselling from all specialists, and certainly for anaesthetics, you may not be able to, find a clinic that will see someone that early. I think your physician will be able to, or your mito specialist should be able to give you some information. In general, what we do in pregnancy is we get an anaesthetist to see the pregnant woman, and we get advice from them around what anaesthetics would be suitable or not suitable. So we always have to have, plan, even if the plan is not to have an epidural or a general anaesthetic and have a normal birth, we all know that things can happen unexpectedly, and we need to have plans in place for in case someone needs an emergency cesarean section or wants to have pain relief in labour with medication. So a consult with an anaesthetist during pregnancy is what we would usually arrange for someone with a medical condition.
With that kind of decision making, Lisa, obviously being a first time mum or someone that's already being a mum, I suppose women feel a lot of pressure to kind of have a plan of how they, want their pregnancy and their labour to look. And I'm sure having, mito, a lot of the time it can be an invisible disease to those. Do you have any tips for women to advocate for themselves in that time where things may not be going to script? Say they thought their fatigue was fine, but they're getting to a point in their labour where they need to make a change or a decision, like for their own sake. I know that a lot of pressure can be put on I suppose, doing things what people would say the right way.
Mm.
How would you like kind of encourage someone that has, mito to kind of speak up for themselves? Because you can have like your midwives and doctors, but sometimes they're not necessarily there on the day and know the background story to its full effect. Do you have any tips around, that for women, encouraging them to, seek their best kind of treatment?
Yes, I know. Although we hope to provide continuity of care to women who have special medical considerations, yes, it's not always possible. So sometimes a woman might be in labour with a team she's never met before, and then it may be very hard to kind of really express what her wishes and preferences are, especially if they change. It's, we can all write things down on paper beforehand, but things can be very different at the time. I think your support person is really key in kind of helping communicate with your care team when you're not able to. So, your support person, if they can come to some of your antenatal visits, I know that's not always possible with work, but particularly towards the end of pregnancy, at that 36-week visit, that's a really good time to sort of encourage and plan the person who's going to support you in labour to be there, so that you can have the discussions with the support person there, and so they can get an understanding of the way the system works also, and also for them to feel more empowered to advocate for you. I think it's really important. As you said, there's a lot of pressure socially to get through pregnancy and childbirth and parenthood in a certain way. I think it sometimes can be work against women to have, when there are really high expectations put upon them. So I think, you don't have to apologise for anything that you choose to do in your pregnancy or birth or as a parent. You have to put yourself first. The best thing you can do for your baby is really to look after yourself. So if that means, okay, I've given labour a go, this is not working, I'm exhausted, I think, I need a cesarean or I need help with the baby being delivered, it's fine to say that. Conversely, if you're saying, I really want to give vaginal birth a go, I know everyone's concerned about how I'll cope, but I really want to give it a go, you should be supported in that as well. And then again, I think another point where there's a lot of pressure put on women is on how they choose to feed their infant. And again, if you're sleep deprived, fatigued, if you have to put your own health first, then you should not feel pressured to feed or look after your infant in a way that is detrimental to your health. So that was one of the things that did come out in the literature review, which I found very kind of revealing. There was a case report of a woman who had respiratory compromise. She needed to use a CPAP machine when not pregnant to assist with her ventilation at night. And after having the baby, she had spent so much time caring for her baby, her own respiratory function deteriorated because she wasn't able to look after herself as much as she would have. So I think that's where the village is really important, and being able to ask for help when you need it. So you don't have to be superwoman. It takes a village to raise a baby. So I think that's important, to be kind to yourself as well.
Yeah, most definitely. Thank you so much, Lisa. Kiralee, was there anyone to answer the poll? Shall I?
Oh, I've already closed it off.
Oh, you've closed that? Okay. All right. Yeah. Excellent. Let me just back. Okay, I've just popped up some upcoming Mito events that we have. The Mito Community Summit is coming up soon, which will be held in Victoria this year. If you can't make it, we will be running a webinar online. So we've got lots of interest in that, so it's very exciting. And as Lisa, you shared before, the resources from our website, we've got the links here again: guidance for pregnancy with Mito and options for building your family. And that's all we have today. Thank you so much, Lisa. Appreciate your time. And yeah, You too, Kiralee. Couldn't have done it without you.
Thank you very much for your time and your effort.
Thank you very
Great.
much. It was a pleasure to be here today.
Excellent. Thanks, Lisa.